Raise your hand really high if while you were traveling here, you saw someone on your airplane wearing a face mask. Lots of hands up in the room. Keep them up, keep them up, keep them up. Now raise your hand and clap if you think I came here on the airplane wearing a face mask. No claps in the room, interesting. Okay, well, I'm gonna save my answer till the end, and I hope you'll understand why I made the choice I did. So this presentation is coming to you in 3 parts. First, I'm going to talk about COVID-19 in the context of other outbreaks. Then I'm going to talk about why the outbreak now and why I'm not surprised. And then I'm going to talk about the good, the bad, and the ugly. First off, though, I would like to thank Susan Harriman and the college for inviting me here to speak to you. I'm always excited to talk about my favorite topics. This is a real passion for me. And I'd also like to thank 2 people who sent me their slide sets as I was preparing for this talk. Dr. George Rutherford from UC San Francisco and Dr. Art Reingold from UC Berkeley. Also, I do want to preface this conversation in that I'm an infectious disease epidemiologist. And epidemiologists study the disease in populations. I am not a clinician. Clinicians study and work on disease in individuals. There's an important distinction there. I'm also going to put the disclaimer out there that the views reflected in this presentation are mine alone. They don't reflect the views of the organization I work for, RTI International, or any other entities. So let's jump right in. Novel coronavirus disease, COVID-19, is a new disease for humans. It's importantly a zoonotic disease. And I mention that because zoonotic diseases tend to be more dangerous to humans. They're diseases that generally live in animals and on occasion jump over to humans. They also, importantly, tend to be more dangerous than other infectious diseases. Examples you've heard of before: Ebola, anthrax, plague, hantavirus, and some forms of influenza. So you hear a little bit in the news about bird flu, which causes sporadic outbreaks in Asia, and we watch very closely. That's a zoonotic form of influenza that could be very dangerous were it were to spread widely. There are other forms of influenza that are not zoonotic. So coronavirus, from a historical perspective, were considered different. They're actually were considered relatively inconsequential. They cause globally, on average, 10 to 30% of all colds. And similarly, coronavirus circulate in mammals and birds. Nonetheless, we have seen 3 dangerous zoonotic coronaviruses affecting humans. In 2002, there was the severe acute respiratory syndrome, or SARS, outbreak, which had a case fatality rate of 9%. We saw that start in Guangdong, China, and then go to Hong Kong, Canada, and beyond. The case fatality rate is the percentage of people that get sick who die from the disease. Then in 2012, we saw MERS, Middle Eastern Respiratory Syndrome. That had a higher case fatality rate of 34%, so more dangerous than SARS. MERS is still out there causing sporadic outbreaks, mostly originating in the Middle East, while SARS has disappeared since that first epidemic. Now we have COVID-19, which is the 3rd of these more lethal coronaviruses to affect humans. Let's take a close look at this graph to see how COVID-19 compares with other infectious diseases. On the x-axis, we have transmission rate. This is the number of people one sick person gives the disease to. On the y-axis, you see the fatality rate. So the higher up, the more deadly, and the further to the right, the faster the outbreak can spread. So let's look at MERS. 38% of people with MERS die, and before they die, they infect less than 1 person. So it's not easy to become a large outbreak. They generally tend to remain small. And one thing to keep in mind about MERS, it's mostly spread by coughing and sneezing on others. Measles falls on the far right of this graph. One sick person infects on average 15 other people, while only 1 out of 100 will die from the disease. This means that a measles outbreak can grow very fast. Measles, though, importantly, is pretty unique as infectious diseases go. It's highly infectious, and that's why you see the 1 to 15, because the virus can remain airborne. That means that it can stay suspended in air for some time. The data is showing that COVID-19 falls somewhere between the Spanish flu of 1918 and polio. The latest estimate is that 1 person with COVID-19 gives the disease to 2.3 people. Now, these are very early estimates, and I have seen that a range on that number. So I think it's far too early to know that for sure, but it's not up at 15. It's more at the 1, 2, 3 in terms of how many people will get sick from one person who has the illness. WHO this week announced the global case fatality rate at 3.4%. Again, that's a number that I've already seen, quite wide estimates at in the general population. Nonetheless, it's very, very important to recognize that it's already known that the fatality rate of COVID-19 varies significantly by age. The older you are, the higher the death rates are. The younger they are, the lower they are. So the 3.4% is the average, with the elderly having a higher one and the younger people much lower. So how does COVID-19 spread, and what's driving the outbreak? So far, with the limited data, it suggests that COVID-19 spreads very similar to seasonal influenza. So close contact with sick people who are coughing and sneezing will put a person at highest risk. It's spread mostly by droplet, and this image is up there, and I've asked them to leave it up there for a bit so people really understand that it's droplets. They fall into, people cough or sneeze, they go into the air, and then they fall down. And the spread of it is generally considered no more than 6 feet for any disease that is transmitted via droplet. So giving a sick person a simple surgical face mask is a good idea, because that avoids these droplets from going out past their immediate area. And unlike measles, the early data is showing that this virus does not stay suspended in air. Looking closely at the data from China, most transmission is occurring within household, not within healthcare settings, or in airports, or on planes, trains, or on the streets, or in auditoriums like this if I were standing here and coughing. And I do want to reiterate this point, because if you just read the news, it's hard to tell what's going on. And so it's really, in China, at least they saw that household transmission was one of the drivers making that outbreak grow bigger, just like it would be in seasonal influenza. The most common symptoms for COVID-19 are fever and a dry cough, and then some people are experiencing shortness of breath and difficulty breathing as well. And I'm going to include here some things that I've been hearing just in the last day being here that's confusing for people if they read the news. The question is, why are we closing schools? Why are people canceling flights and those things? The issue around school closure is not necessarily about reducing the risk for younger kids. It's that schools are one of the focal areas in a community where diseases spread quickly and then spread out back into the community. So kids go to school, they mix with lots of people, their hygiene practices are tentative at best, and then they go home and hug the parents and grandparents, and you get a lot of mixing. So So the schools, it's not about the kids being most at risk, it's really about ways to contain any disease in a community that's infectious. So why now, and why I, as an infectious disease epidemiologist, am not surprised about COVID-19, I'm not surprised about Ebola, and I'm not surprised about Zika either. There are massive ways the world is changing now that is driving the emergence of infectious diseases that are zoonotic in nature, like Ebola, Zika, hantavirus, and others. The world's population has doubled since 1960 and is slated to double again in the next 40 years. Major growth for the last 20 years has been in Asia, and next the major areas of growth will be in Africa. There are 38 megacities now globally. Those are cities with over 10 million people, and by 2050, more than 2/3 of the global population will be living in a megacity. Infrastructure likely cannot keep up, resulting in high density and crowding and inadequate sanitation. The massive population growth will accompany economic growth, and with that comes high demand for animal protein. This means that in the areas with the largest population growth, as well as economic growth, you'll see many more chicken farms, pig farms, and so far, the massive growth in those kind of farms is in China and India. There's also further globalization of goods and services and transportation, and as we've seen, the increased speed at which people move all around our planet. The annual growth rate of just air travel alone in Asia is 6% per year. In Africa, it's 5% per year, and in the Middle East, it's 7%. So the trend is going much like this. So what alarms me the most is that we know where the risk of zoonotic and emerging diseases are the greatest. We create great models with the best data, and we can see those in a map that highlights areas of yellow where we know right now we are at highest risk of where diseases will emerge. Note the areas in yellow. Wuhan lands right in the yellow, and it's a megacity with 11 million people living there. It's also the regional transportation hub with 1 million people flying out of Wuhan to different places in China and the world. By 2050, there'll be many more megacities, and those will be focused in China, India, and Nigeria, exactly where you see areas already highlighted in yellow where we know now that the disease risk of emerging diseases is highest. Now back to the COVID-19 outbreak in China. The good news is that the China outbreak seems to be waning. I read the news this morning, and there were no new cases reported yesterday in Wuhan, meaning that, and when I say the outbreak waning, it means that there's less cases that day than there were the day before. That signifies that an outbreak is being contained. Of note though, and this is really important, China's response has been the most ambitious, agile, and aggressive disease containment effort ever in history. What you've seen there has never been done before. They restricted movement of people into and out of Wuhan and 12 neighboring cities. That has not been tried since the Middle Ages during the plague outbreak. People were instructed to stay home for a month. They implemented social distancing measures like closing schools, public transportation, and suspended public gatherings. They had thousands of people tracking sick people and their close contacts to make certain that they stayed isolated from other people. Again, good news. We've learned a lot from this experience in China, and we have insights now on the best way to treat sick patients so that they are less likely to die. We have a better understanding of who is at the greatest risk for severe disease, And we've identified public health measures that work. Things like case detection, rapid diagnosis, isolation, early treatment, rigorous contact tracing, and limiting household transmission. In the US, to be very clear, this is no longer a travel-associated outbreak only. There is community-acquired infection in the United States, so this is a domestic outbreak as well as a global outbreak. The issue around testing has been challenging. Until this week, the testing has been limited to the US Centers for Disease Control and Prevention laboratories in Atlanta. And as of this week, they've been able to roll out testing to the state laboratories of public health, but they're just ramping up this week. They've also extended the criteria for who can be tested. So early on, it was people who had traveled or were contacts of people who had traveled to certain countries, and now there's going to be a lot more testing of people in the United States with no known contact with travelers. This is going to be important because as more testing comes online, we are going to identify more cases because we just weren't able to find them before with the limited testing capabilities. The other good news is that vaccine development is moving quickly, and their estimates are that there could be a vaccine available within a year, and again, that's unprecedented speed. Some bad news. Until a vaccine is available, we need to do everything we can to stall the spread and minimize risk. So things like closing schools is an effective way to slow down the spread within a community where you know it exists. So far, we are seeing that one person gives the infection to about 2 people, so the outbreak can quickly grow, 2, 4, 8, 16. With a 3.4% case fatality rate globally, the more people who get sick will die. While it seems relatively contained in China, it's spreading globally quickly. We're seeing big disruptions in the global supply chain. 80% of active pharmaceutical ingredients are manufactured outside of the US, and the majority are in China and India. This could impact our ability to treat sick people here in the US. The really ugly, the public health measures that we know work will be difficult to achieve in the United States and elsewhere in the world, where the healthcare and public health systems are weak. So this is the kind of approach that China took is really unprecedented and extremely aggressive in terms of public health. We're not used to that aggressive approach here in the United States. Lower and middle income countries will be hit far worse than higher income countries, similar to what was seen in the 1918 pandemic influenza. And beyond COVID-19, we're seeing more outbreaks and global epidemics now than ever before, and the number is increasing with each year. And it keeps me awake at night that only 1/3 of all countries worldwide have the capacity to detect a dangerous outbreak in their country and report it to the global community faster than it can spread outside their borders. That is a very big deal. We are not prepared domestically now or for the future. This is true here in the US and globally. Prevention, detection, and response to disease outbreaks requires an all-of-society approach, support from all sectors, public, private, across the aisles. So here's what I'm asking you to do. You've heard me now, and then you're going to go and talk to many people that you know who can help make a difference. I'm asking you to advocate fiercely for increasing and sustaining funding for public health preparedness and global health security. The time to act is now to decrease our risk for the future. Similar to the adage that parents are only as happy as their least happy child, from a global health security perspective, we're only as safe as our least safe country. So to stay safe individually and minimize your risk, it's the same as what you would do for seasonal influenza. Wash your hands with soap and water frequently. Stay home if you're sick, or if someone in your home is sick. Make plans with your family, make plans at your workplace, consult CDC and your local and state health departments for guidance. The news is often not exactly correct and also puts your focus in places where it's maybe not as productive. And as promised, the answer to the question, I did not wear a mask en route here. I will continue flying, though if I'm sitting next to someone coughing, I'm gonna try to move, and I'll really badly want to give them a face mask. Thank you very much.